Hello again. This is Dr. Kamas. I'm Professor Emeritus at the Ohio State University. I'm a transplant surgeon. The talk today is about brain death and organ donation. It is have been accepted for a long time in all the world. However, there is some controversy still in the Arabic or the Muslim world about this topic. So today we will talk about deceased donors, and we know that really the bottleneck or the main problem with the transplantation is the shortage of organ donors. So the transplant communities around the world have done so many things to improve the situation. And when you look at every program or total donors, you'll find that about 70% of them are deceased donors. In the past, they called them cadaveric donors, but this terminology is obsolete now, so they are called deceased donors. And when you take the deceased donors only, they used to be 100% brain dead donors. Deceased donors is our topic today, and this term is the accepted really term. Before they called them cadaveric donors, and that is not accepted. It's becoming an obsolete term with the changes in terminology and technology and improvement in or increase in the number of donors with the slightly different aspects of just deceased donors. In any case, the problem of organ donation is really the main problem, that there are not enough organs to go around for the need of the transplant patients who are, or the pre-transplant patients who are on the waiting list. So despite the use of living donors, still about 70% of the transplants are done from deceased donors. Now, when you look at the deceased donors, many years ago, 100% of them are brain dead donors. Now, with the use of the donation after circulatory death, the situation have changed. And slowly, as we became more comfortable with the death after cardiac arrest or after circulatory death, it became, and improved the survival, it became really a main aspect to increase the number of donors all around. So when you look at the deceased donors nowadays, you will find that 80% of them are brain dead, and anywhere between 20 to 30% of them are donation after circulatory death, or DCD, that is the abbreviation for that terminology. But today we will not be talking about DCD, we'll talk about brain dead donors. So what is really brain death? Is it a new idea? As we know from one of the previous videos, you may remember, maybe not, that the first successful human kidney transplant was done between two twins in 1954 in Boston by Dr. Joseph Marie. And after that, with the improvement and the immunosuppression, it was felt, and more understanding of the immunology, it was felt that probably non-twins could be transplanted too. And then around 59, which is 5 years after the first successful kidney transplant, the idea of the brain death was conceived, and People really worked hard on it, and about 68 Harvard criteria became very clear, which means another 9 years later, and it didn't really become a law until about 81. And there are guidelines in the United States, for example. There are major guidelines for the brain death and definition and diagnosis, but each hospital has their own process to declare brain death as long as they are within these guidelines. So anything that causes brain injury would may result, if that injury is so severe, and will result in brain death. So cardiovascular accident, what we call a stroke أو الجلطة، trauma، حوادث السيارات طبعا بكثرة، أو gunshot wounds, cardiac arrest, bleeding in the brain, severe convulsions. So all these things may lead to brain death. We need today to add really some definitions, an idea about the diagnosis, who makes the diagnosis, who is suitable for donation, and of course the details of the criteria and brain death diagnosis and so on is probably, and the anatomy is probably better be obtained by discussion with a neurosurgeon or a neurologist. But in any case, the brain death, it means complete cessation, basically stop of any brain function, whether it's cerebral or the thinking part or the reflexes or the brain stem. So it's really complete cessation of the brain as well as the brain stem. So what does that mean? It means that there is no blood coming to them, they are not functioning, and that person is really dead. That is not going to survive. Even if you keep him on the machine, maybe 24, 48 hours, 72 hours, and then the heart will stop. Usually the diagnosis here in the United States is done by a neurologist or by an intensivist or by a neurosurgeon. And of course, they are a team that they are different from the transplant team. So the transplant surgeon, with his loyalty to his transplant patient or potential recipient, is not allowed to participate in this process. So he's not allowed to declare a person as brain dead or even be part of the care. Usually, those physicians rely on the clinical examination and they can make the diagnosis that way. However, as I have mentioned, the protocols may be different from one hospital to the other. Of course, usually, you have to. There are certain criteria to fulfill the diagnosis of brain death. Of course, the person has to be in a coma, so you cannot be just simply on a breathing machine. No movement, no too painful stimuli, absent cranial nerve reflexes such as apnea, for example. You cannot breathe. If they take the breathing machine out, disconnected from the endotracheal tube, that person will not initiate any breathing movement at all. No coronal reflexes, no gag reflex, and so on. So more or less, the physician can make the clinical diagnosis. However, some hospitals may insist on EEG, some hospitals may insist on cerebral blood flow, or may do both. Way back, they used to do sometimes cerebral angiogram and so on to confirm the diagnosis. And even with all available technology to you, still the diagnosis has to be done in certain conditions where you don't want any confounding factors outside of the brain injury itself. So you want to make sure that there is no hypothermia, or there is no hypoglycemia, no induced coma, and no medication side effects. So you have to exclude the situation that may affect the brain function before you can declare the brain death. Okay. So once you declare the person as brain dead, who would be a candidate to donate, because you could be a person very old or very sick and so on. So you declare them as brain dead, and then between you and the family, they would not be organ donors. So usually you want to screen them and make sure they don't have cancer that can be transmitted to the recipient. The electrolytes are in a good shape, so hypernatremia or very high sodium, sometimes that may affect the liver function, and some donors may have been declined because of that. You want to make sure that the organ you're going to be transplanted, or you're transplanting, or you're going to be taking from this donor is functioning very well. So if you are considering taking a liver from this donor, and the liver enzymes are in the 4,000 or 5,000 and they are not coming down, then you know that's probably the liver have suffered severe injury and probably not suitable, and so on. So there is a lot of thinking and intellectual discussions that go behind the scene, and testing and so on, to make sure that the donor is really suitable. Now, the infectious disease is probably a lecture by itself. Many years ago, as soon as you discover that the patient is Hep C, you decline the donor, decline the offer. The patient is Hep B, you decline the offer. The patient has cancer, you decline the offer. The person has fatty liver, you decline the offer. The creatinine is more than 2, you decline the offer. But things have really changed, and the infections now are treatable. And nowadays, for example, we use the hepatitis C really routinely. Hepatitis C donors. HIV donors used to be complete contraindication. Nowadays could be given to HIV recipient, and so on. And once the diagnosis is established, a new process starts. The new team from the organ procurement organization comes in to take care of the donor, which is really a very complicated situation. And the management of the deceased donor is very important, because you want to preserve the organ function. Otherwise, if you take bad organs, they will not really function in the recipient, and you will end with a bad outcome. Now, having said that, the brain death donation is still really very controversial in the Muslim world, and I think it requires discussion. And if you want to set it up as a new program in your country, you would need to prepare the society and prepare the Islamic scholars prior to initiating the program, because once one or two of them give a degree that it is not suitable, or Islam is not allowing it, or something like that, then you can basically will not be able to launch your program, and you will end in a failure. So preparation of society and education continuing is very, very important before you launch your program. I think I came to the end of this just little tour around the brain death. In the next video, we'll talk about donation after circulatory death. It used to be called donation after cardiac death. and we'll talk a little bit about the donation process and what goes on in the management and the offers and so on. I really appreciate your listening, and I hope it will raise some discussion, even if there is some disagreement. And please, if you don't mind and you find the mini lectures useful, to subscribe to the channel or share it. And I wish to see more medical students and young doctors participating. I would love it if I see you write a comment, and thank you so much and have a great day.